Hi, today we will be discussing Chapter 28 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of the eye. This slide set is part 1 of 3 on eye disorders causing diplopia or double vision in this chapter. The first point to clarify is whether diplopia persists in either eye after the opposite eye is covered. If it does, the diagnosis is monocular diplopia. The cause is usually intrinsic to the eye and therefore has no dire complications for the patient. Corneal aberrations, uncorrected refractive error, cataract, or foveal traction may give rise to monocular diplopia. Occasionally, it is a symptom of a malingering or psychiatric disease. Diplopia alleviated by covering one eye is binocular diplopia and is caused by disruption of ocular alignment. Inquiry should be made into the nature of the double vision, mode of onset, duration, intermittency, diurnal variation, and associated neurologic or systemic symptoms. Binocular diplopia results from a wide range of processes, including infectious, neoplastic, metabolic, degenerative, inflammatory, and vascular. One must decide whether the diplopia is neurogenic in origin or is due to restriction of globe rotation by a local disease in the orbit. In this set of slides, we will discuss 5 etiologies, namely myasthenia gravis, disorders affecting the oculomotor nerve, the trochlear nerve, and the abducens nerve, and multiple ocular motor nerve paralysis. Myasthenia gravis is a major cause of painless diplopia. The diplopia is often intermittent, variable, and not confined to any single ocular motor nerve distribution. Serial measurements of a variable fatigable ptosis, often accompanied by diplopia, are helpful to establish the diagnosis. The diagnosis can be confirmed by an IV edrophonium injection, which produces a transient reversal of eyelid or eye muscle weakness. Blood tests for antibodies against the acetylcholine receptor or the musk protein are frequently negative in the purely ocular form of myasthenia gravis. If restrictive orbital disease and myasthenia gravis are excluded, a lesion of a cranial nerve supplying innervation to the extraocular muscles is the most likely cause of binocular diplopia. The oculomotor nerve is the third cranial nerve, and it innervates the medial, inferior, and superior recti, inferior oblique, levator palpebrae superioris, and the iris sphincter. Total palsy of the oculomotor nerve causes ptosis, a dilated pupil, and leaves the eye down and out because of the unopposed action of the lateral rectus and superior oblique. The advent of an oculomotor nerve palsy with the pupil involvement, especially when accompanied by pain, suggests a compressive lesion such as a tumor or circle of Willis aneurysm. A lesion of the oculomotor nucleus in the rostral midbrain produces signs that differ from those caused by a lesion of the nerve itself. There is bilateral ptosis because the levator muscle is innervated by a single central subnucleus. There is also weakness of the contralateral superior rectus because it is supplied by the oculomotor nucleus on the other side. Occasionally, both superior recti are weak. Isolated nuclear oculomotor palsy is rare. Usually, neurologic examination reveals additional signs that suggest brainstem damage from infarction, hemorrhage, tumor, or infection. Injury to structures surrounding fascicles of the oculomotor nerve descending through the midbrain has given rise to a number of classic eponymic designations. Nothnog syndrome Injury to the superior cerebellar peduncle causes ipsilateral oculomotor palsy and contralateral cerebellar ataxia. In Benedict syndrome, injury to the red nucleus results in ipsilateral oculomotor palsy and contralateral tremor, chorea, and athetosis. Claude syndrome incorporates features of both of these syndromes by injury to both the red nucleus and the superior cerebellar peduncle. In Weber syndrome, injury to the cerebral peduncle causes ipsilateral oculomotor palsy with contralateral hemiparesis. In the subarachnoid space, the oculomotor nerve is vulnerable to aneurysm, meningitis, tumor, infarction, and compression. In cerebral herniation, the nerve becomes trapped between the edge of the tentorium and the uncus of the temporal lobe. Oculomotor palsy can also result from midbrain torsion and hemorrhage during herniation. In the cavernous sinus, oculomotor palsy arises from the following conditions. The etiology of an isolated pupil-sparing oculomotor palsy often remains an enigma, even after neuroimaging and extensive laboratory testing. Most cases are thought to result from microvascular infarction of the nerve somewhere along its course from the brainstem to the orbit. Diabetes, hypertension, and vascular disease are major risk factors. Aberrant regeneration is common when the oculomotor nerve is injured by trauma or compression. Miswiring of sprouting fibers to the levator muscle and the rectus muscle results in elevation of the eyelid upon downward gaze or adduction. The pupil also constricts upon attempted adduction, elevation, or depression of the globe. Aberrant regeneration is not seen after oculomotor palsy from microvascular infarct and hence vitiates that diagnosis. The trochlear nerve, the fourth cranial nerve, originates in the midbrain just caudal to the oculomotor nerve complex. Fibers exit the brainstem dorsally and cross to innervate the contralateral superior oblique. The principal actions of this muscle are to depress and intort the globe. A palsy therefore results in hypertropia and excyclotorsion. The head tilt test is a cardinal diagnostic feature. Vertical diplopia is observed upon reading or looking down and exacerbated by tilting the head toward the side with the muscle palsy and alleviated by tilting it away. The abducens nerve, the sixth cranial nerves, innervates the lateral rectus muscles. A palsy produces horizontal diplopia, worse on gaze to the side of the lesion. A nuclear lesion has different consequences because the abducens nucleus contains interneurons that project via the medial longitudinal fasciculus to the medial rectus subnucleus of the contralateral oculomotor complex. Therefore, an abducens nuclear lesion produces a complete lateral gaze palsy from weakness of both the ipsilateral lateral rectus and the contralateral medial rectus. Foveal syndrome occurs after dorsal pontine injury and includes lateral gaze palsy, ipsilateral facial palsy, and contralateral hemiparesis incurred by damage to descending corticospinal fibers. Millard-Gubler syndrome results from ventral pontine injury and is similar except for the eye findings. There is lateral rectus weakness only instead of gaze palsy because the abducens fascicle is injured rather than the nucleus. After leaving the ventral pons, the abducens nerve runs forward along the clevus to pierce the dura at the petrous apex, where it enters the cavernous sinus. Along its subarachnoid course, it is susceptible to meningitis, tumor, subarachnoid hemorrhage, trauma, and compression by aneurysm or dolichoectatic vessels. At the petrous apex, mastoiditis can produce deafness, pain, and ipsilateral abducens palsy known as Grenadico syndrome. In the cavernous sinus, the nerve can be affected by the following conditions. Unilateral or bilateral abducens palsy is a classic sign of raised intracranial pressure. The diagnosis can be confirmed if papilledema is observed on fundus examination. As was mentioned previously, for isolated trochlear or oculomotor palsy, most cases are assumed to represent microvascular infarcts because they often occur in the setting of diabetes or other vascular risk factors. Treatment of abducens palsy is aimed at prompt correction of the underlying cause. Patching one eye, occluding one eyeglass lens with tape, or applying a temporary prism will provide relief of diplopia until the palsy resolves. If the recovery is incomplete, eye muscle surgery nearly always can realign the eyes, at least in primary position. For multiple ocular motor nerve palsies, these should not be attributed to spontaneous microvascular events, affecting more than one cranial nerve at a time. Neuroimaging should focus on the cavernous sinus, superior orbital fissure, and orbital apex, where all three ocular motor nerves are in close proximity. In a diabetic or immunocompromised host, fungal infection is a common cause of multiple nerve palsies. In a patient with systemic malignancy, carcinomatous meningitis is a likely diagnosis. The cancer-associated Lambert-Eaton myasthenic syndrome also can produce ophthalmoplegia. Giant cell temporal arteritis occasionally manifests as diplopia from ischemic palsies of extraocular muscles. Fisher syndrome, an ocular variant of Guillain-Barré, produces ophthalmoplegia with areflexia and ataxia. This ends part 1 of eye disorders causing double vision or diplopia. Next set of slides will deal with 5 more eye disorders that cause double vision or diplopia.